So in this video, we're going to begin looking at the processes of a client with heart failure. So the definition of heart failure is pretty simple. It's a syndrome. It's not actually a disease in and of itself, related to other underlying comorbidities. So any structural or functional cardiac disorder that impairs the ability of the ventricles to fill with or to eject blood. So because now I have a bad pump, my heart is unable to produce enough cardiac output, which means I'm not able to perfuse effectively. Heart failure is not a disease. Again, it's a syndrome, usually associated with long-standing hypertension and coronary artery disease. And we have said repeatedly that if you have plaque one place, you have it every place. And then we discussed how basically what we see is this long vicious cycle of clients who have hypertension and then end up with respiratory disease processes or have diabetes or kidney injuries, and they all kind of progressively make each other worse if we don't do things to correct or to treat the underlying cause. So the term heart failure indicates myocardial disease and a problem with contraction, so that's the systolic dysfunction, or the filling, that's the diastolic dysfunction, and the filling happens when the heart relaxes. And that can lead to either pulmonary or systemic congestion. And that's why, again, it's so important to understand where blood flows to and how it's going to back up when we have these other kind of underlying comorbidities. We know that heart failure is a progressive lifelong condition that is managed by lifestyle changes and medications to prevent episodes of what we would call either acute on chronic or acute decompensated heart failure. Normally when you have heart failure, your compensatory mechanisms take over to maintain perfusion. We've looked at increased heart rate, increased blood pressures. We've looked at issues with preload and afterload, and that's how your body is going to maintain perfusion. But sometimes those compensatory mechanisms do fail, either because we were non-compliant or we had forgotten to get our pneumonia vaccination, our flu vaccination, some other underlying comorbidity causes this exacerbation to happen, this worsening to happen. So as heart failure develops, the body again will have those compensatory mechanisms involved. We've said that the systolic heart failure is going to result in a decreased volume being ejected, so that decreases your cardiac output. That in and of itself is going to cause your body to stimulate the release of epinephrine and norepinephrine, those medications that are going to cause an increased heart rate and an increased blood pressure. Now, because I have a decrease in volume, I'm not able to perfuse my kidneys as well. And your kidneys are like, hey, what about us down here? So their response to that is to produce more renin. And then that promotes the formation of the angiotensin 1, the whole ACE to angiotensin, and then angiotensin 1 to angiotensin 2. Unfortunately, since I know I already have a pump problem, that's going to promote more vasoconstriction. It's going to increase my SVR, and it's going to make my heart have to work harder to maintain cardiac output, which is going to long-term make my heart failure worse. So this is a reduction of the contractility of the muscle fibers of the heart and increases the workload. It's a pump problem. And again, that's going to stimulate your compensatory mechanisms, and that's just going to keep happening over and over unless we are stepping in and doing things to treat the underlying cause. So when we're looking at this from a health promotion and disease prevention type of category, we're talking about maintaining an exercise routine, active lifestyle, your DASH diets, when we talked about dietary approaches to stopping hypertension, because that's a big underlying cause, making sure you're changing the way that you are living a lifestyle. We want to teach smoking cessation if possible, and we want to teach about the importance of compliance with the medications. There are going to be a lot of medications to choose from, And again, because it's a progressive disease, it's going to walk through different stages where you can add different medications to help decrease all of those signs and symptoms and decrease those acute on chronic situations, those exacerbations. So we've kind of looked at heart failure and we've examined that it's going to cause those compensatory mechanisms to activate, which is going to increase your heart rate. It's going to increase that force of contraction, but it's also going to increase your afterload, that SVR. So here we see how everything, even from a heart failure perspective, is a pump issue or a volume issue. So we looked at systolic failure. This is the most common cause of heart failure. It's a pumping problem. So what we're going to be looking for are decreases in that left ventricular ejection fraction. We've looked at an ejection fraction before, and we've defined it as simply the volume of blood being pumped out by the left ventricle. So in this case, if we're going to define it as an EF of less than 40% with systemic and pulmonary congestion, and notice it's both, even though this is a left-sided mostly problem, because if you have left-sided, you generally have right-sided. So if I had 100 milliliters of blood in that left ventricle, I'm only pushing out 40 milliliters. So that means I have 60 left, and you still have more blood coming in from the atrium as well. So, and that's just going to cause this continuous backup of fluids, and that's how you end up with the systemic and pulmonary congestion. Diastolic failure is resulting from cardiomyopathies. It can be left ventricular hypertrophy or chronic hypertension. It can be caused by aortic stenosis. Anything that basically is going to cause that left ventricle to have a change in its structure and function. So we compare systolic and diastolic heart failure to left-sided heart failure and right-sided heart failure. And this just kind of does a generalized breakdown. You see that fluids may back up into the lungs, causing shortness of breath. We'll look at that further. But left is lung and right is circulation. So we see fluid in the abdomen, the legs, the feet, peripheral edema. Generally, we've said that clients start off with left-sided heart failure and then develop right-sided heart failure. Mostly. You can have right-sided heart failure related to respiratory diseases, that cor pulmonale that you'll learn about in the respiratory portion. It's just that you have right-sided heart failure related to, pulmonary artery constriction, pulmonary hypertension. That's cor pulmonale. Anything, the delays that transfer of blood from the right ventricle into the pulmonary circuit. And here we see, again, the systolic and diastolic definitions. Again, it's a pump or a volume issue. And when you're going into your NCLEX, if you look at it from that kind of perspective, that's what they're going to be looking for. Do you know what to do if you have signs and symptoms of left-sided and right-sided? And it's basically, it doesn't change when we look at our cardiovascular system. Everything that we do from a basic nursing standpoint is pretty much the same, and we'll just look at those things again. So there are certain issues that increase the likelihood of you developing that syndrome of heart failure, and it's these cardiomyopathies. So here we see the definition of a dilated cardiomyopathy. So you can see here how this left ventricle is enlarged. It's super dilated, and it doesn't ever go back to this, what we would call a normal pump. So you can see that I have a decrease in the muscle mass here that makes it a dilated cardiomyopathy, and it's going to make it harder for this heart to squeeze effectively. You have a hypertrophic, so now instead of we seeing this enlargement in the thinning of the muscle, you have this enlargement of the muscle. So that's going to decrease the amount of space that you have to fill with blood. So look at this space compared to this space. I have less volume to pump out, and it's harder for the heart to contract because it's thicker. restrictive, you can have this same inside, but these muscle itself has become almost fibrous, thick. It's lacking now the ability to squeeze because of that tightness. So that's a restrictive cardiomyopathy. We've said that you're going to have different processes to treating heart failure. And that's not for the nurse to decide. That's going to be the healthcare provider. They're going to look at the client. They're going to look at the ejection fraction. They're going to make a decision on which medications or lifestyle modifications to prescribe. But we go from A to D. And just like nursing school, you want to have an A and you don't want to have a D. And anywhere in between, we're going to do things. We're going to improve ourselves. So hopefully we're going to do things to improve these clients. So it would be nice if we found our clients in stage A, but just like hypertension and just like a lot of our other cardiovascular diseases, we've talked about the fact that this is asymptomatic for a really long time because of those compensatory mechanisms. But if we are fortunate enough to catch it in stage A, it means basically, we haven't developed a structural change yet. We're going to do those dietary approaches to stopping hypertension. We're going to teach them diet, exercise. We're going to say stop smoking and do all the right things. Maybe prescribe a statin, right? And maybe prescribe an ACE inhibitor. An ACE inhibitor is going to hopefully prevent structural changes. Remember that we talked about ACE inhibitors and they prevent ventricular remodeling. Unfortunately, most of the time that we actually get a diagnosis of heart failure, they're already in B or C. So if we recognize this, they're probably already on blood pressure medications. Then we could consider that ACE inhibitor as well and a beta blocker. Now, a beta blocker is going to decrease the amount of oxygen that the heart needs to work more effectively. So when you see the words decreases myocardial O2 consumption, it just needs less oxygen to do the same amount of work. And it's also going to decrease your systemic vascular resistance because it is a blood pressure medication. So we're getting added benefits there. Remember, you do want to be careful with beta blockers if you are also using beta adrenergic respiratory medications, albuterol. That's not really going to stop us from using albuterol in the real world, but I see those practice questions all the time. And it's like, oh, be careful using a beta blocker with albuterol. Well, I still want to open up the airways in the real world, and I still want to lower the blood pressure. Just notice that it can cause bronchospasms and heart blocks and all those great things that we've talked about previously. We're moving on to stage C now. So we're still going to do all those other things that we have already done, realizing that if they've had hypertension, they are probably already on these medications, and we may want to add digoxin, a digitalis, or an inotropic medication to improve the pump. Hopefully they're already watching their diet, but we may need to remind them about the 2 to 3 grams of sodium diet for our clients so that they don't retain fluid. So if we're moving from stage C now all the way to stage D, you're still going to continue all of those measures, but because that EF now is probably around 10%, we may have to do more extreme measures. Left ventricular assist device and LVAD. If it's less than 10%, sometimes they are a candidate for a heart transplantation, especially if it's one of your kiddos with left ventricular hypertrophy. We can put them on continuous dopamine, duvotamine infusions, those inotropic medications to improve heart rate and blood pressure. But again, that's not great long term. Or we can discuss with them about the possibilities of hospice care. So when we're looking at the signs and symptoms of left-sided heart failure. There are some easy things out there to help you remember which is which. So with left-sided, we're looking at drowning, and with right-sided, we're looking at swelling. So we're looking at left-sided now. So we'll start with dyspnea. That's the obvious one. If I have crackles, I would expect to have dyspnea. You sit the head of the bed up, increase their oxygenation, encourage turn, cough, deep breathe, and send a spirometer. All right, because it's going to be difficult to breathe. If it's difficult to breathe and you're not perfusing, you're going to have weakness and fatigue. You can have issues with not being able to sleep well because of that sudden onset of dyspnea. So nocturnal paroxysmal, a sudden onset of dyspnea. You would expect an increased heart rate because of the compensatory mechanisms. Pulmonary congestion is going to lead to that nagging cough, that pink, frothy, blood-tinged sputum. And then you would still want to do their daily weights. For me, if they're having an acute decompensated episode, daily weights are not as important as accurate eyes and nose. Remember, whatever goes in has to come out. And if it's not, that's why they're gaining the weight. So that's left-sided. And you're going to add in your urine output. Right-sided, we see signs and symptoms in the circulatory system. So you see swelling of the peripheral. You can still see weight gain. Swelling is edema, but now you have its pitting edema. JVD, which to me is still swelling. You can still see lethargy and fatigue. You can have an irregular heart rate, which could be tachycardia, bradycardia, AFib, aflutter, runs of PVCs, runs of PACs. Issues with going to the bathroom at night. And then your abdomen may get larger. It's ascites, so it's still fluid accumulation. Altogether, we have you're either drowning or you're swelling, and probably most of the time you have signs and symptoms of both. In children, heart failure is pretty uncommon, right? Most of our kiddos have respiratory issues. We know that. However, we do have some congenital defects that are going to cause a decrease in perfusion. And again, we are going to focus on signs and symptoms of decreased perfusion and doing nursing interventions that are going to help them out. So whether it's putting their knees to their chest or increasing their oxygenation or monitoring for their difficulty in feeding, those are things I have to be able to look at in an infant and say, these are potential signs and symptoms of heart failure. I would still expect maybe auscultate some pulmonary congestion, but the earliest thing and probably the most benign thing in infants is simply going to be tachycardia, right? That's the easiest thing for me to say because an infant can't sit there and tell me that it's having difficulty breathing. I have to be able to assess that. So I can see that by their respiratory rate, by their heart rate, by their refusal to eat. If you can't breathe, you can't eat. So they're going to have this failure to thrive. So eventually those signs and symptoms are going to manifest as respiratory distress and hypoxia. So pay close attention to your kiddos. For any diagnosis, our goal is to treat and control the underlying comorbidity. And I know it says heart disease here because that's generally what causes it. But if I have an exacerbation of COPD, that can lead to an exacerbation of heart failure. If I have an infectious disease process, that can lead to an exacerbation of heart failure. Because we do expect these clients to be on diuretic medications or inotropic medications, it's important that I look at those electrolytes, especially potassium. Potassium is going to be huge for us. Hypokalemia, hyperkalemia increase our risk for dysrhythmias exponentially. Hypoxia is a reason to be in a dysrhythmia. Taking digoxin, especially in the presence of hypokalemia, is a great reason to develop a dysrhythmia. We're going to make sure that our patient population are receiving their vaccinations as dictated, and then we're going to teach them about the signs and symptoms of all the medications they could be on. So we have to go through the laundry list of all those cardiac medications, and we'll look at those here. So you see on our example here that I'm bad on cash, right? So these are the things that I would expect as the nurse to look at long term. Beta blockers. We've talked about how the fact that beta blockers are kind of, used cautiously with albuterol. It's a beta blocker versus a beta agonist. They cause bronchospasms. They cause low heart rates. They mask the signs and symptoms of hypoglycemia because it lowers your heart rate and your blood pressure. That's a lot of patient teaching. That's a lot of side effects that our clients may or may not be okay with. We've talked about the use of ACE inhibitors, and they promote vasodilation. They reduce mottling. ACE inhibitors, however, will cause your potassium to actually go up. So you're at increased risk for hyperkalemia. So again, we have to now teach them signs and symptoms of hypo and hyperkalemia. We're going to do inotropic medications, or we could expect inotropic medications and diuretics. So digoxin, dubodamine, dopamine. Dig, I can send them home with. It's a PO medication. I can give it IV push as a loading dose. I can use it in the ICU with dubodamine or dopamine. And then diuretics are obviously going to be to take that volume off, right, to help the pump. So that's my bad. We always expect the increased use of oxygen if it's needed, right? Don't go slapping on a non-rebreather on somebody who's talking to you and not having issues breathing. We could expect the use of nitrates, either continuous infusions to decrease preload and afterload because it's that vasodilator effect. We could use nitro paste. We could use PO medications, specifically isosorbide mononitrate and isosorbide dinitrate. It's got nitrate in the name. Or up to that sodium nitroprusside if I'm using it in the ICU setting. Then I want to teach them the importance about monitoring their blood pressure, because these nitrates, because they decrease preload and afterload, are going to increase your risk for orthostatic hypotension. Calcium channel blockers, not too bad. They're going to promote vasodilation. They're going to reduce SVR. But calcium channel blockers will also delay the electrical activity in your heart, and you could end up in a bradyarrhythmia or a heart block. We're going to teach them about their activity, their lifestyle, dietary approaches to stopping hypertension, the importance of exercising 30 minutes a day, sodium restrictions. We've talked about the 2 to 3 grams a day if needed. And or we can add hydralazine in there. And again, hydralazine is that antihypertensive. It's the only one you're allowed to call a blood pressure pill because that's its classification. From a testing standpoint, there's 2 big ones that we care about. Everybody knows chest x-ray, and the only thing you're going to see on the chest x-ray is the enlarged heart and pulmonary infiltrates if you have them. But the big ones for us are the BNP and the echo. So the BNP is the cardiac enzyme I'm looking at to see if their heart is pumping effectively. If it's not, it's stressed. You're going to see an elevation in those numbers. Your institutions will determine whether or not they like the BNP or the pro-BNP, and those numbers are also going to change. So that means if I give you anything, it should be exaggerated. If NCLEX gives you anything, it should be exaggerated, or we should be giving you the reference ranges so that you are able to identify them like you would in the real world. When we talked about our echoes, there's the invasive one versus the non-invasive one. One can be done at the bedside. The other one's can be sent down for a procedure because it's through the esophagus versus over the thoracic cavity. So those are going to look at the shape and structure of your heart. You can look at the heart size, you can look at the valves, you can look at the ejection fraction. And generally speaking, that EF is going to be low in most of our clients with heart failure. So here we kind of see that this heart is very dilated. So if you can look at this and go, yeah, I can recognize that this is a dilated heart and it's going to have a hard time pumping, you are able to recognize signs and symptoms of where blood is going to go to. So blood is coming from the pulmonary circuit. So over here is your lung, and fluid is going to fill in your lungs. So we know then that we want to monitor our daily weights, but more importantly, I want to monitor those eyes and nose. We're going to listen to lung sounds, assess for shortness of breath, look for dyspnea on exertion, administer oxygen as prescribed. You can just do nasal cannula, you can do CPAP, BiPAP, you can do high humidity, you can do an oximeter. It just depends on the client. We know that we want to do frequent vital signs, looking at their hemodynamic pressures, because you can end up in a cardiogenic shock or a hypovolemic shock if we're not treating this client correctly. And our first probably thing is just to raise the head of the bed, right? Monitor their ABGs, their electrolytes, chest x-ray findings, their oxygenation status. You will have to know a normal PaO2, PaCO2, just like you would in a respiratory exam, but we learned that earlier. You know, PaO2 greater than 80 is what everybody wants on a test. It's oxygen. Oxygen is good. CO2 is 35 to 45, that PaCO2, because 35 to 45 is everything in nursing, it seems like, right? It's sodium is 135 to 145, and then you have potassium is 3.5 starting out. So it's just a generalized kind of number. Depending on the client situation, we can encourage bed rest and schedule periods of rest with ADLs. We want to talk to them about making sure they're not trying to get up and walk to the bathroom by themselves. We want to do our dietary restrictions if prescribed, and then emotional support for the client and the family. That's your Maslow's. So a couple things I can look for now is that if I do have a client who is experiencing acute pulmonary edema, you'll move from the more generalized nursing kind of stuff to the more specific. So we look at MOP or HOPE, positioning, oxygenation, morphine. Morphine to decrease that anxiety, to decrease the respiratory distress symptoms, because respiratory distress is all about fluid in the lungs, and hopefully it will decrease preload and afterload. So there I say it kind of backwards, but it's MOP. And over here we're talking about the administration of rapid-acting loop diuretics. It's furosemide, generally speaking. And realize that that is going to cause diuresis, so you need to monitor your eyes and nose, but you also need to monitor your lung sounds and your potassium level and the SpO2. And here's your HOPE. It's head of the bed to 45 degrees or higher, oxygen, your push medications. So you see furosemide, you see morphine, and are also our vasoconstrictors. So that could be a beta blocker, it could be a hydralazine, it could be sodium nitroprusside if it's in an extreme condition. And then the fluid and sodium restrictions. So just a couple ways to help you remember those nursing interventions. So according to NCLEX, this is kind of what I would expect if I had to place these things in order. So least invasive to most invasive, right? Raise the head of the bed, administer oxygen as needed, listen to lung sounds, make sure that they have IV access if I have to do IV push medications. If they have a diuretic or morphine prescribed, we can do that. Insert a Foley. If none of that helps, prepare for intubation and ventilation and transfer to the ICU after you document the event, your actions, and the client's response. So it's just a simple way of walking through the steps of what would I do for acute pulmonary edema. And acute pulmonary edema is really the defining criteria to say that a client is in acute decompensated heart failure. Because remember, it has to include that backup of fluids into the pulmonary or systemic circuit. So again, we'll look at things to decrease preload, decrease afterload. We've talked about each one of these already, but just examples here. So I could give furosemide IV, and we know that if it's through a central line, we don't want to go too fast. Regardless of what you've seen the healthcare providers do, it's over a couple of minutes depending on the dose. Again, watch their potassium. You could expect nitroglycerin, even though it seems kind of counterintuitive. But nitro does decrease SVR, it decreases preload. If we want to decrease afterload, you look at more sodium nitroprusside, that morphine sulfate again, your ACEs and your ARBs, and your calcium channel blockers. If we're going to use a digoxin, so for each client taking digoxin, they have to take the apical heart rate for 1 minute. Or I'll teach them to hold the medication if the pulse is less than 60, or if it's an infant, if it's less than 90, if it's a child, it's less than 70. And then we're going to observe all these clients for nausea, vomiting, dysrhythmias, bradycardia, toxicity. And we have to know our normal dig levels to do that, right? It's 0.5 to 2. So I just kind of remember, the lower the number, the better. The higher number, greater than 2, is going to be indicative of dig toxicity. And it's important to understand that dig toxicity can happen at any point. It could happen after the first dose. It does not matter, so you're still going to look for all those same signs and symptoms. Well, let's think about it again. Realistically, if I have an infant and they become dig toxic, they're not going to be able to look at me and say, I'm having yellow halos. But what we will see is nausea and vomiting, tachycardia, those early signs and symptoms of dig toxicity. We've talked about vasopressors, dopamine, dobutamine. They'll be used continuously. Beta blockers to decrease that myocardial O2 consumption. And again, our vasodilators, just examples there for you. So those are the medications you have to know for the test. And that's going to be basically for every cardiovascular disorder. Digoxin, diuretic therapy, your ACEs and your ARBs, your beta blockers, calcium channel blockers, your nitroglycerin, your hydrolysine, and your potassium replacements. You have to know those medications. The other thing that dig is notorious for doing is causing arrhythmias. In this case, we're going to call this a bradyarrhythmia. What we are actually seeing are periods of asystole. So I'll try to do this with the mouse the best we can. When we talked about our dysrhythmias, we said you have to use your toolbox. So I'm going to look for the regularity. So up here, because this is a continuous tracing of one client, I see that they have P. I see that there's the R wave going up here, the S wave coming down here. I do see a little ST segment depression, which is indicative of ischemia. And then I see a T wave and a U wave. Don't really need to know about the U wave, but I see a normal PQRST. And I see consistency. And then all of a sudden, I see nothing. And then your heart's like, oh, wait a minute. I didn't want to not beat there. I want to maintain perfusion. So we said digoxin interferes with the electricity of your heart. So it's definitely interfering with the electricity of your heart. So you are experiencing periods of asystole. Now, can you imagine if we don't do something to fix that? And we see this client, he beats again here. And then I have this other delayed, this pause here. And then he beats again. And then I have another pause. And then he's like, okay, I'm going to start doing what I do for here, like maybe 4 or 5 seconds. And then I'm going to have another pause. We don't want that to happen. So remember, digoxin gets worse in the presence of hypokalemia. This is a real client. This is not one of those made-up ones. We had this client. They were on the TCU. They were on digoxin. This was the outcome. So you can imagine that we quite literally stopped the digoxin and used Digibind. So again, these are just the medications that you are expected to know for the test. And here's some examples of the names. Most of these you're probably familiar with just from hypertension. I'd say probably the only one that we really didn't talk about here is the use of anticoagulants, but you remember if they have a history of blood pooling, that then they are at risk for developing a clot and could end up with the PE, MI, or stroke. We've already said that hypokalemia causes ventricular dysrhythmias. We're going to teach the client about those signs and symptoms, and here we do see a drug alert about hypokalemia and hyperkalemia. And then again, we see the easiest, the earliest ones are going to be anorexia, nausea and vomiting, fatigue, headache, depression. Visual changes, yeah, that's a tough one, especially in our infant population. And then we do see late signs and symptoms. So our other person over there, he didn't experiencing any of those with his dysrhythmia, with his periods of asystole. He went straight to the dysrhythmias. So that's his bradycardia and his AV block. So you will see it usually in the generic form of the digoxin immunofab or Digibind. And that's our antidote. Some just general diagnostic tests. We've talked about these things that we want to monitor, right? The ECG, make sure they're on continuous telemetry, looking for dysrhythmias. We're looking at the chest x-ray. We're looking at an echo. We can do stress testing. We can send them to the cath lab for an angiography or a PCI. We expect to monitor the digoxin levels, their bleeding times, their clotting times, so PTTs, INRs, depending on what they're on. We can expect to look at their electrolytes because we have issues with fluid volume, either excess or fluid volume depletion. I want to monitor their BUN and creatinine because we talked about that decrease in perfusion to your kidneys. Heart failure, because of the fluid accumulation, will have an effect on your liver, so we can look at the liver enzymes, but those are going to take a really long time. But we can also look at the serum albumin because we know one of the things we can do to move fluids back into the vasculature is to give albumin. Of course, we're going to look if there's any underlying anemia or polycythemia, and then we can look at their ESRs or their CRPs or whichever one your healthcare setting prefers, just to look at their inflammatory process. We'd probably say throw in the lactic acid there as well. Long-term therapy, if there's clients experiencing heart failure with an EF of less than 10, we could consider an LVAD. This used to be a really bad potential. They were going to require hospitalization, but now we have LVADs that the client can actually wear. So it's interesting, but it's going to be pretty invasive and pretty extreme. To me, an LVAD, you should know what it is, a left ventricular assist device. It's used in clients with heart failure, but that's generally about it. They're going to monitor for signs and symptoms of acute decompensated heart failure, signs and symptoms of infection, palpitations, dysrhythmias, and all that good stuff. But, the basic nursing portion of this, the NCLEX portion of this, is just knowing that this is for clients who have a really bad EF. We've already talked about the client education, diet, exercises. We've said, the 2 to 3. Here we say the sodium is usually restricted to 2.5. Again, that's just really physician or healthcare facility preference or based upon the signs and symptoms. Fluid restrictions are not generally required unless they're having an acute exacerbation. We want these clients to maintain hydration. It's just when they're holding on to a lot of that fluid that we have to put them on the fluid restriction. Weighing them at each time, every day at the same time, same clothing is very important to us. And again, we see this reference range. If you see weight gain of 3 pounds over 2 days or 3 to 5 pounds over a week, you need to contact your healthcare provider. So just a little client education when they're getting ready for discharge. Here we see the patient and family teaching guide for heart failure. So you see the health promotions, you see the planning for rest, you see the drug therapy, the dietary consults, the activity, and then ongoing monitoring. And this is straight from your Lewis book. It's nothing different in here than what we have already talked about. It just sums it up in a nice little table for us. So in this example, so we're going to say that this client has admitted to the hospital with an acute decompensated heart failure. Why are we looking at these numbers and what do they tell us about the client? Well, the first thing I can see is that this client is tachycardic. All right, so again, I'll try to show this the best that I can with using the mouse to draw on here, but when I'm looking at the rhythm, I do see that I have regularity, right? But I need to look at our PQRST as well. So PRI looks okay, right? What I do see here is this ST segment does not return to that isometric line. So what does that tell me? That tells me that my client has experienced either ischemia or injury, right? ST elevation is a diagnostic test for an MI, and MI is because of ischemia or injury. So this, I know right now, right away, that I need to be considering putting an ECG in my plan because they are tachycardic and they are experiencing ischemia. Well, here in the SpO2, it's 88%. I know that that is not my 95 to 100, and as long as this client doesn't have COPD, I can explain why I have or might have some ST elevation, because I am hypoxic. I have a bad pump. How do I know I have a bad pump? Because I look at their blood pressure and I see that their blood pressure is 75/40. So if you got a bad pump, you cannot maintain perfusion. And 75/40, I don't even have to calculate that map to know that it's bad. We know anything less than 90 is indicative of poor perfusion. And then I have a respiratory rate of 40, which I would understand because this is all my compensatory mechanisms being activated. So I would probably say I need to go in and I need to fix the problem, whatever is going on with this client. One, I need to improve the pump. So I can do that through the use of digoxin. If this were in an ICU setting, I could consider the use of those other inotropic medications. I could consider dopamine, dubodamine, things that cause vasoconstriction because I need to improve the pressure. I know that I'm going to raise the head of the bed and increase their oxygen because they're satting 88%. I would probably expect, because it's a poor pump and a poor SpO2, that the client would have crackles. So I could expect to auscultate crackles. So I know I need to listen to lung sounds. And then I need to do a lot of evaluations of those therapies. So how am I going to evaluate the increased oxygenation? Well, that ST segment should return to baseline. The SpO2 should go up. I'm going to evaluate the use of the inotropic therapy by looking at their blood pressure, looking at their MAP, and then just generally looking at the client's overall condition. Are they alert and oriented? Are they lethargic? Are they obtunded? Those other bad words, malaise, fatigue, that are telling me that my client is not perfusing like they should. So just a nice little way to sum up somebody who is in acute decompensated heart failure and what I could expect for those vital signs. And that is heart failure. And again, this is the basics of nursing when it comes to care for a client who either has chronic heart failure or who is admitted for one of those acute on chronic or the acute exacerbations of heart failure.